So first of all, Priya, thank you so much for being our guest. Since this July that we have created this series of Tell Us a Case Safety Story. So just a word about this series. There is some rules of the game. So it's, first of all, it's twice a month, once in English and once in Hebrew. And it's open to everybody. Whoever speaks Hebrew can come. And the idea is to have a case study with adverse event that we present and that we can discuss all the action that we can set up to prevent this to happen again. And it's about 30 minutes and the objective is not only to present cases that it's very something that we're doing all the time in our job, but to train the professional to be more proactive. What does it mean? That what we want is that whenever we receive an adverse event which is really striking, we have to ask ourselves, what can I do to prevent this to happen again? And this is really what has triggered for me all my passion for pharmacovigilance since the very beginning of my career in pharmacovigilance, to ask me myself, what action can I set up to make it less dangerous or less serious, less severe? So this is exactly what we want to do. And if any one of you want to present cases, you are more than welcome. Just, I would like to present Priya, even if it's a little bit not useful because everybody knows Priya. So Priya is a principal scientist at the EMA. She has many roles, and one of them is a coordinator of the group Risk Communication in the ISOP, the special interest group that has been created in ISOP. And I'm a member of this group, so I'm very glad to have our coordinator speaking today. And she has also taken the role of the coordinator for the Science Guide to Vaccine Safety Communication, which was issued last year. And I think that it was like extraordinary to have this document that we need so much right now. She has written hundreds of articles, and she has also written recently a book on risk communication, on which she is really an expert. So I'm sure that I've forgotten a lot of things, but one thing that I must say that I know Priya for the beginning of ISOP for years and years, and that I'm very glad to welcome you. So please, Priya, you can share your slides now.
Well, welcome everybody. Thank you so much, Irene, for this really very sweet and kind introduction. And I'm very happy you're providing this forum for a presentation. And I'm also touched by everybody who's just online, and many names I know and many names I don't know. And it's just wonderful. Thank you so much. I'm doing screen share now. And let me see, what I have for you today is a little bit different. It's not a case of an individual case safety report, but it's a different kind of case. It's a really important story for us at the EMA, the European Medicines Agency. But also it's absolutely in the same spirit, which was just mentioned by Irene, is about what can we do that adverse reactions don't happen again. So the philosophy is the same, story is a little bit different, because what we had an experience at EMA. We called for the very first time for a public hearing, and that public hearing was on Valproate. It's an anti-epileptic substance, and we got stakeholder input, and I want to describe to you what kind of input we got and what are the implications, what have we learned for the future. And these are my own views, although this is obviously a study done by the EMA. It was led by me and with colleagues from Prague and the Pharmacovigilance Risk Assessment Committee. Also, the rapporteurs were involved. So that's a great collaboration. Well, when we think about pharmacovigilance engagement in broader terms, I want to first tell you that this term has not yet been defined. And we did actually, with another researcher from the University of Amsterdam, Patrick Brown, we did a search in drug safety, our journal from ISOP, or our ISOP how do you say, our way to speak to the broader public, to the journal. And we found that engagement was used in many articles, but it was actually never defined. And there were also other terms used like involvement or participation. And so we thought we first need to conceptualize. And what I'm showing you here is a bit of a mimicry, sort of word cloud. People like word clouds nowadays. This is actually not a real word cloud made by many people. This is actually the cloud in my own head, so to say. And when I started thinking about engagement, all these different concepts came about, like, is it consultation? Is it information? Is it a dialogue? Is it decision making? What about pharmacovigilance, patient engagement with spontaneous reporting? How do the healthcare professionals, which roles do they have? Is it about getting representative engagement? And what about the minority populations? Then many people talk about the concept of the patient voice. There are also broader scientific concept in like science communication, citizen science. So there are a lot of terms, and definitely it shows that engagement is not yet very well conceptualized. So in the EMA, together with our colleagues from the member states, we created an impact strategy it is the impact strategy of the Pharmacovigilance Risk Assessment Committee, and it looks actually at investigating impact of regulatory decisions. And part of this strategy is also to build capacity for engagement with patient communities and healthcare professional organizations with the view to minimize risk and also evaluate risk minimization measures. So in this context, we had obviously to think, okay, we need to conceptualize what do we mean by engagement. And the outcome of this collaboration with Patrick Brown I just mentioned from the University of Amsterdam is we started with a quite simple definition, which is like engagement is an ongoing knowledge exchange between parties. It sounds very simple, but it was actually a lot of thinking behind. Is it about knowledge? Is it about this, that? And we also figured out that there are various dimensions on engagement. So obviously, how many people do you involve and how diverse are these people? Then in terms of how much knowledge do you exchange between stakeholders, and how can you adopt this for mutual understanding? And then there are various levels of it comes just like you inform each other, or you really consult, or you really participate in something you want to solve together and get somewhere together. And then you also have the texture, which are the interactive dynamics of what engagement feels like to all people involved, and how the own values come in, how it shapes motivations, and how ultimately we change behavior together, in this case for safer use of medicines. And the three dimensions are actually linked in quite complex manner, both in terms of processes and outcomes. And now with the Valproate case, then what happened? So we did this conceptualization, and at the same time also we started having our consideration for our first public hearing in early 2017. And this was also a very complex case because we had already minimized risk in 2014 to prevent exposure in pregnancy with which has a potential for delayed and long-term developmental adverse effects. In addition to birth defects seen immediately in a child, you can also see late effects, and they're very severe. It's Then obviously the drug was not only used for epilepsy, but also other indications, bipolar disorder, severe migraine. It was all about women's health and also obviously reproduction. We were wondering about what is the trust of our stakeholders in what regulators are doing, how can we communicate well, what risk minimization measures can we do better. And with all of that, we went into a public hearing and also a dedicated stakeholder meeting. And this was actually even informed by a consultation we did before with stakeholders. So there was a lot of engagement throughout the whole process. And in autumn 2017, we had this public hearing. And it was the very first time we've done that in the EU. And well, what was the outcome? Before I tell you more about the engagement, the outcome was that we had further restrictions in the use of the product in female patients and a comprehensive pregnancy prevention program. But what was really novel, and there was a direct outcome from the public hearing, was that we combined in a regulatory decision this pregnancy prevention program with the call for individualized care for the woman, like counseling on the disease, on her options about having a child or not, or how to time this, and what about changing treatment and all this disease management, but also somehow taking decisions for her own life and family life. And that's something we try to address in that pregnancy prevention program in the context of making a demand for counseling for the woman. And that was really new. And the other new element is that there was a decision taken to have a visual warning on the outer packaging, and that was directly corresponding to the request from patients to have more visual tools available, which are easier to remember and easier to see and have a bigger impact. Now, in terms of the impact of the public hearing, I've already said it gave us a multi-perspective insight into, oh, sorry, that's not what I wanted to do. Sorry. Here I am. It gave us, I'm just trying not to see, actually, I have to minimize the gallery view. Okay, great. So we have the multiple perspective insights into healthcare, and this was something which was otherwise really difficult to get. Like, what does really happen with our risk minimization measures once they have left the regulatory desk and also the printing office, so to say, of the marketing authorization holder? What we learned was, as I've already described to you, really instrumental for practice decision making. And there was a survey done right after the meeting, and the majority of PRAC members said that they really learned something new, and also said that it would make a difference to their assessment. And they were able to confirm that actually the previous risk minimization measures from the previous assessment 2014 were considered by patients actually an excellent toolkit, but the problem was that it wasn't properly delivered. So really here it became absolutely clear that the process from regulation, even though healthcare is not regulated under medicines regulation, that somehow we have to arrange a better outreach. And 100% of the stakeholder respondents felt that the hearing was a positive experience, and 88 felt they would make a difference to the PRAC recommendations. And this, by the way, this is available as a video. So if you really wanted to see this, is a 5 hours video to see the whole public hearing. But it's absolutely amazing because the patients who were talking in their own language, and obviously it was a live recording. It was the first time for them to speak in a public forum, which was also live recorded, and a lot of they felt they present really a patient community. And we even had a young a woman speaking who as a child through the exposure in Utero was affected, and she took the courage to speak, and it was a huge achievement for her, because she has these developmental effects playing on her concentration, and she was doing brilliantly, and was such an effort behind also to get everybody on board and to enable people to speak comfortably in that room with the EMA. So what we did in the case study was that while this whole process was going on, already started to analyze stakeholder input also from a different perspective, and I'll come to that in a moment, and then draw proposals for the future. And that was comparing the public hearing with the follow-up dedicated meeting, which happened 2 weeks later. And the method which was used was actually to look at the input, not so much from the side of what questions were asked and what people answered, but completely restructuring the input alongside domains of implementation. So when you think of an implementation process, you have material, the material gets delivered, and then it gets read or it gets pinned somewhere, and then people remember it or they don't remember, and they change their practice or they don't change their practice, and they talk about it. And at some point in time, it reaches the patient, and the patient can profit from that measure, right? So there is a whole chain of implementation. And to really understand what are success factors or critical factors, failure factors also for making that process a success or not, you can see that a lot of domains are important. Like, first of all, you need to know if your risk minimization measure, provided it will be implemented in the most perfect way, will actually really be able to reduce the harm from a purely pharmacological point of view. Or so the second domain is about the access. Like, if that risk minimization measure is there, will people actually adopt that? Will that also interfere with actually maybe not having access to the medicine anymore, because it's so complicated that people choose to prescribe something else, which then might need a medical need unaddressed, for example. The third domain is about being really audience tailored. And the fourth domain is how that risk minimization measure would be compatible with the structures and the resources within the healthcare system, which is different from how it can be integrated, and that's the fifth domain, into a healthcare process. And why is that difference? There is a difference between structure, resource, and process, because you could well have a risk minimization measure you can beautifully put into your process, because, for example, it's something about how you dispense the medicine, and you can make an intervention which just fits in the process perfectly well, but you may not have the resource to actually implement the process. But it could also be the other way around. You have resource, but for some reason your process in a hospital is so complicated that you just don't get it done, right? So that's why there are two different domains. And the sixth domain is really about looking at timing, like how do you get things done quickly so that people profit from the risk minimization measure immediately, and how do you get it sustainable, that in the long run there is a behavior change and all patients are safe. And that tool has been called ASSET, an analyzing stakeholder safety engagement tool, and that's how we have analyzed the input at the public hearing vis-a-vis the input from at the dedicated meeting. Now, in terms of result, we found out that stakeholders provided a wide range of risk minimization measure proposals, but many of them were also beyond what we actually could do through regulation. So, for example, reimbursement of contraception or things like this are not within what we can decide. Patients also converged remarkably with healthcare professionals. So there wasn't this divide between these two major stakeholder groups, but there was actually some divergence among the different stakeholder professionals. And that was more remarkable than what was seen between patients and healthcare professionals en gros. And this divergence related to the informed choice objective, the therapeutic place of Valproate, the appropriateness of the risk minimization measures, and the delivery. And then we had ethical aspects which really emerged as quite relevant to the regulatory decision making. So the ethical aspects about the medical needs of the mother vis-a-vis the needs to protect the child, but also knowing that a child from a mother who is not optimally treated for epilepsy will also suffer. So that was a complex relationship, and also what to do when somebody has fallen pregnant. You cannot stop giving the best care. So these ethical aspects were very relevant for the decision making. And then there were also quite crucial input gaps were identified from an implementation perspective. So we got a lot from the public hearing, but there were also a lot of missings to still optimize that implementation process. Now, in terms of the results, to say what can we change, we found that there were 3 areas where we have precise pilotable proposals. And the first area is really on agreeing between all stakeholders that the risk minimization measures are appropriate, so that we get a real buy-in and that we agree this is the best we can do under the circumstances, and that is also implementable in healthcare. But and we need to catalyze that leadership for implementation together, like I'm coming a moment to so a few more examples. But then also we need to build up the stakeholder input, that we get it input on all critical elements of the implementation process, so that we can actually optimize the risk minimization measures. And in a third area, we need to collaborate to monitor the implementation and then also evaluate together the risk minimization measures. Now, what does that mean in practice? Well, there are 9 pilotable actions, and in the first area of agreeing the appropriateness of the risk minimization measure is really to conduct meetings in a way that it creates common ground, shared problem ownership, exchange of expertise, so that we are looking more, rather than just collecting individual opinions and say, okay, we've listened now to a lot of different perspectives, also see if we can facilitate that people come to common solutions, that we can agree solutions. So that's another, an additional step of what we have done so far. And then also motivate leadership in healthcare organizations to implement. So we got, for example, some commitment from some organizations who said we will do publications in our journals, we will discuss this in conferences, but what more can we do? How can we work on to see that clinical guidelines are taking up our recommendations from regulators, and also support healthcare professional training in terms of communication. Now, it's not that regulators can do it all, but to give ideas and to see together with healthcare who can take over certain missing elements from the implementation process. And the missing communication skills of healthcare professionals was something even healthcare professionals themselves admitted, and was also very much shared by the women who spoke on the public hearing. And then the pilot action A3 is about increasing also the transparencies on agreement, because what I have also learned in other regulatory areas is that once you actually share openly why this is maybe not the best solution, well, is not a solution which can make everybody happy, so to say, but why you had to find a compromise between different elements, then people all of a sudden say, oh, now we understand this, the best you could actually do, we're going to support you. And I have seen that in other areas, particularly in policy development, and it increases really the adherence and the enthusiasm to stick to certain rules when people understand why they are as they are. So in the area number B, about building stakeholder input, here we think that we can use this checklist I have presented to you before, which was for analyzing the content, also as a checklist to generate questions, and also a discussion guide, so to really see that all the areas of the implementation process are appropriately covered, and that we identify also barriers to implementation, and that we then can discuss these barriers and enable us together, and also hopefully find the solutions. And in terms of collaborating for monitoring implementation, at the moment we monitor in quite large timelines, like after 3 years, after 5 years, and now we want to move to shorter timelines, like within the first year or the first 18 months, to evaluate already the risk minimization measures. And we want to do that with healthcare professionals and patients together, and obviously also with the MAH, and to be really much more proactive, be more in real time, and be able to improve and support the implementation process and the dissemination of the information. So we really need to do high quality research, which is participative with the stakeholders. Now, Also, I want to now almost at my end of my presentation, this is the very classical benefit risk cycle where we well, yeah, in the upper part, we have evidence, we integrate that, assess our evidence, we come to regulatory decisions, and then we decide on risk minimization measures, and we want to then evaluate and improve. And what you see here at around time number 7, so to say, in the lighter blue, is that the implementation of risk minimization is actually really part of that cycle. And it really, the risk minimization measure and pharmacovigilance goes through healthcare. So the regulatory side goes through healthcare and then comes back into the regulation. And obviously together with industry, we can assess the impact and then improve. And you see that with the little red arrows, there is a number of opportunities for patients and healthcare professionals to input into that process so that we can design and evaluate risk minimization measures the best way with the impact from real world healthcare. These are the references. There are the reference obviously from EMA, but also the publication from Patrick Brown and the one on the stakeholder assessment. They are all open access. I also would like to highlight that EMA is publishing early next year a revised module GVP number 16 on risk minimization measures, where we are very much looking into improving tools for risk minimization measure as well as the methods for assessment. And you're very welcome, obviously. ISOP, I hope, will also comment. And yeah, and Irene kindly mentioned already the book. By the way, I'm not making any money with the book. I really just want that the messages are widely disseminated. It has a number of chapters from cognitive scientists, social scientists, media scientists, like all the different disciplines, which can actually help to inform, well, basically can help to research various aspects of the communication systems in a better way, so that we can have better communication interventions and also have better outcomes and evaluate them as well. So with that, I would really like to thank you for being here, and I hope you enjoyed this case, and I look forward to your questions. I do stop sharing the screen so we can engage better. If I manage stop share. Yes, okay, great, thank you so much. Thank you. It's nice to see you smiling.
May I just have one question? And just to say, I unfortunately I didn't have a chance to introduce myself at the beginning of today's meeting. I just would like to say that my name is Liana Kaisyan. I am a newcomer in this organization, this society. I just joined ISOP very recently, just 2 or 3 weeks ago. And I'm very happy to meet all of you, and thank you very much for this beautiful presentation, very interesting. I hope in the future we can collaborate even more. Just to say, I'm a physician, I am child neurologist by my first education. I live in Armenia, in Yerevan. And I just, during the last 7 or 8 years, I started to work in the field of pharmacovigilance. I was an head of pharmacovigilance department in one of the local CROs in Yerevan, and just recently established my own PV center. And that is the reason I decided to join ISOP and also join these local meetings to learn more. So thank you very much, and nice to meet all of you, saying again. One question, I just coming back to your presentation, you spoke about ethical part of this issue, like valproate acid and fetal problems, and from the one hand, and from the other hand, problems with mothers who are receiving valproate for many years, because this is maybe the only treatment option for for that person, for example, and they are, for example, seizure-free because of valproate as a treatment. And now this is, I guess this is really challenging to decide whether they need to continue treatment or maybe they have to switch to the another treatment option just to save the life of fetal, but from the other hand, stay seizure-free. So how you, just wondering whether you are collaborating with healthcare professionals just to resolve this, or how you think it is better solution just from the point of view of ethical issue of this, just your point of view on this.
Yeah, I think that thank you, Liana. First of all, welcome to ISOP. It's great you've joined, and I hope you will enjoy yourself and we will learn a lot from each other.
Yes.
Thank you for your question as well. Yes, in fact, what was paramount is to I think the real challenge was choosing between like having pregnancy like as a contraindication, but on the other hand, not close completely all doors to give the best treatment to the mother when that is the only treatment available, which really works for sure. And also not forcing healthcare professionals into a situation where they feel they do an off-label use for which they could have a litigation problem later. So it's really finding that balance. And the way how it has been solved is it has now the use is allowed only in under the conditions of the pregnancy prevention program. And that pregnancy prevention program is worded in a way that is very strict to limit the exposure, but with the counseling and some softer wording, it recognizes the dilemmas for the healthcare professionals. I think that's the best we could do. And obviously regulators cannot take the responsibility away, or we can support healthcare professionals, but ultimately it is the responsibility and the co-decision making between the healthcare professionals and the patient, and in that context also their partners. And that's something where we cannot take that away. And it was a very difficult discussion also to find the right words, and also not to weaken the pregnancy prevention program to an extent that it would again not be as strict as it was supposed to be. I have here some questions in the chat box about how can outreach be improved. I really like this question. Thank you, Kalindi. I think you are really, this is really a question of implementation, because it's true that as regulators, we take one decision and then we publish once, and the healthcare and the additional risk minimization measures are delivered. And then obviously there are processes in place to see that healthcare professionals get a sufficient stock. So that's something we have now put also in our revised GVP guideline. But that's certainly not enough. And this is about disseminating through other channels, and also the integration of the measures in healthcare processes. And I think that's where we need mechanisms for reminding people at the point of care of the information they need to know, also having maybe training activities, and that goes all beyond what we can demand as regulators. And that's why I think the collaboration with healthcare communities will be so important. But it's also not so easy, because there are plenty of healthcare professional communities, and not everybody is having the same vision about which healthcare professional should take which role in the whole implementation process. And I think that's where we need to get more agreement. And as I said, we are not regulating healthcare, so but we are very open to the engagement and somehow supporting finding solutions. But that will also be very much depend on each country, and we are a European body, and ultimately a lot of that implementation will have to be facilitated at national level. And then can this tool be used to assess other? Yes, that's a good question. So far it has been it has not been derived specific. Well, so what I have done is, and you will see that in the paper, I first took 3 approaches to implementation theories, and I put the tool together, and then I tried the tool on the stakeholder input we had from another dedicated meeting in 2014, and I tried if it works. And with that validation exercise, I fine-tuned the tool. And then in 2017, when I used that input, I had actually to add the ethical dimension, because that didn't come up before, and is also not part of at least not of the 3 implementation science approaches I had used. So so you're absolutely right. We would have to test how well it does for other evaluation, but I think it can be used and made even better. Then there is a question about, yeah, I mean, if you come from industry, please try it out for your risk minimization measures. I love to see that and publish also. I think it's important we use tools, and rather than developing constantly new ones, build up on what we have and improve them. So I would really like to encourage that. And thank you for, yeah, appreciating the paper. That's great. Yeah, I'm still here for more questions. I also know that we are now running over time.
I would like to react to your presentation, because it's touching 2 very important things for me for a very long time. The aspect of integration of the risk management plan inside of the healthcare system, which is in fact described by the implementation process. So, but there is two levels. The first level is how to engage the stakeholders, the healthcare professional, in the healthcare system to adopt and to use the risk management plan. I have been writing several beautiful risk management plans. I'm not sure that they have been implemented rightly and used extensively. And this is, I think, that there is a gap between the regulatory and the very strict, very stringent way in which we work in the industry, and the way we have perceived in the healthcare system. And most of our colleagues in the healthcare system doesn't understand really what we are doing. So I have tried to, this is something that was always bothering me, and I have tried to fill the gap. And since we have created the ISOP ISRAEL, we have started to build up a new concept, a new strategy to use several tools, such as the RMP, but also something that will have more input from the side of the healthcare system. And so we have used the ISMP assessment tool, which is the Institute for Safe Medication Practices. And it's like a questionnaire, like an audit, in fact, of the practices of the drugs in hospital. And then when you can run this ISMP assessment tool for anticoagulants or for high alert medication, then you have a list of all the gaps and what is not working in your hospital. And it's very, very accurate and very precise and very comprehensive.
That's great.
And this is where we can, this is where we can bring the RMP and the risk minimization. And because we can only be sure that it will be efficient, we must have the stakeholder already preparing the risk management plan with the industry. And I think that for the time being, the gap is too large. So I think that you have addressed this point, that in bringing patients and healthcare professionals, what you're doing is starting to make them part of it, and then to be much more, to have much more adherence. And I think that we are at the very beginning of this filling this gap, and that we have to work together to bring all our solutions together. And about the implementation, it's more comments than question. About the implementation, I think that it's also something very new because we had the risk minimization measures, how to measure the impact of what we are doing. And it was always something very difficult to address when you're writing a risk management plan and also to measure. So I think that this methodology of implementation science, it's very important to be inside exactly like you have done. It must be part of the process when you are writing a risk management plan, which will make this gap, which will fill this gap and follow up. What I've seen is that when we were in the hospital, we have a pilot hospital setting up our strategy. And the industry, and it was with anticoagulants, the industry didn't come immediately with a risk management plan, and it was a wonderful opportunity for them to distribute. Eventually they joined, but it shows how much it's difficult not to work in silos, but to really work on this multidisciplinary approach and integrated approach. So really thank you for this new area that you are developing and also for the communication aspect, which is also part of this full of this full scope of this project.
Thank you, Irene. They're great comments, and thank you also for making us aware of that assessment tool. Plus, I mean, your own experience from what you have done in the anticoagulant area together with hospital, I think is a fantastic case study, and I think a lot of learnings from that success can be I think we should maybe, it would be so nice to, and you might have already done that, to have like a generic list of things we can do in order to fill that or bridge that gap. And I look really forward to working together on more solutions and approaches to do that. Thank you.
Raquel wanted to ask a question. Raquel is from Argentina. Raquel, just unmute your microphone.
Yes. Hi, everybody. I'm very happy to share or to attend this excellent webinar. Thank you very much, Priya, and thank you very much, Irene, and thank you very much all the attendees. No, I just only congratulate you because it's very important, and I will take advantage of this opportunity to engage Priya in a webinar for the vaccine vigilance, because today we have the news of that the EMA approved the Pfizer vaccine, and so things go faster than expected, and we will have massive vaccinations very, very soon. And I wonder if pharmacovigilance system of South America or from in Africa or in some countries in Eastern Europe are really prepared to face this enormous challenge of the vaccination of millions of people, because we here we have not databases, secondary databases. We have not. We have indeed some administrative databases, but they are fragmented. They share only some sections of the population, and we have not only one registry, and it's very difficult. And don't know. I know that the Argentinian government has made an agreement with the European Medicine Agency, but our pharmacovigilance system is mainly voluntary. That is, there are I don't know, 3 or 5 people in the central office, and the rest we are voluntary people and working with a pencil and a notebook. And this is very difficult to manage and to conceive even pharmacovigilance or vaccine vigilance as requested now. Now we have to face an enormous challenge, and I really want to commit you, Priya, and the other professionals present here to help us to the Latin American chapter to present a webinar. I expect to present it in February, and for the vaccine vigilance. You are invited. Okay, Ulrich.
Raquel, first of all, so lovely to hear you. Thank you for joining. It's lovely to be connected, at least virtually. And all the points you've made, they're so important. By the way, it was the MHRA in the UK who has authorized the vaccine. We are currently in the EU process and hope to get a positive opinion later this month. But I just would like to alert you to the fact that there is a special interest group in ISOP on vaccines, and they have similar thoughts about webinars. And I think it would be great if you could get in contact with Rebecca Chandler, who is leading that one. And maybe it would be good to join forces. And obviously you want to do that, I guess, in Spanish, which is great. But maybe we can have like something cross-fertilization, and you don't have to we can sort of support each other for this effort. So yeah.
Thank you very much, Priya. Thank you very much. Yes, I have already contacted Rebecca, of course, because I know. Yes. Thank you very much.
Great. Yeah.
Raquel, it's really great that you brought this topic in this meeting, because this is really something that we have started to do in ISOP Israel. And every day we are receiving fake news and calls from friends, from family, forwarding fake news. And it's really something that we feel it's growing and growing and growing. So we have decided to do advocacy for vaccination, and we have started with really general public and healthcare professional in TV, French TV in Israel, and also next week in a French community. And it's something that is really in my heart, because we want to really to set up a conference, really a one-day conference or 2 days perhaps, where we will all join our force, because we all need that. All the countries have to face this problem, so we have to bring scientific and good information, and to restore public trust. And this is our duty, the most important and most urgent in this time of vaccination. So we have in one hand something which is incredible and miraculous, we could say, and in the other hand this threat of infodemic. So we have to work very quickly and to be as active as they are, the anti-vax, and as imaginative. So I think that we really should start very early to set up a group to discuss this project. I have already Peter Peace and several people on board. So
Irene, there is still a question from about effectiveness evaluation reports, if they should be made mandatory. Well, there is so many things we can make mandatory or having other guidance. I personally think that that evaluation report, I mean, they're already mandatory in the EU. But I personally think we need to do more in real time. If that's mandatory or if we have collaborative approaches, I think the latter is always better. But please, there will be that public consultation on the new guidance. So all your ideas as part of Commons supportive, also saying what you like about the guideline is as important as saying what you don't like, will be very, very welcome, because then we can work with that material and improve it. So thank you.
Do we have Ulrich? Do you want to ask a question or comment?
Hello. Hola,
Hello.
Raquel. ¿Qué tal? Buenos días. And regards to Luis. Priya, a question coming back to the public hearing and public consultation. Could you give us a flavor how many participants you had in this public consultation? And do you think it's very first assessment, would you think it's a valuable instrument in the new pharmacovigilance toolkit? We have introduced this with the new legislation in 2012. And
yeah.
Thank you for your presentation. Much stuff.
Well, thank you, Ulrich. Lovely to see you. Yeah, so the public hearing was almost 5 hours. I would have to check for precisely having the numbers, but I can tell you. So there was one presentation from the marketing authorization holder. There was one woman a young woman who was affected as a unborn baby, so to say, from the Valproate exposure. There were about maybe 5 or 6 women who spoke from various perspectives, various countries, various disease areas, different experiences. And we had about maybe 6, 7 healthcare professional organizations. I think that's roughly whom we had. And they were grouped. We had a lot of submissions, and people got together and spoke on behalf of each other. So they grouped, and they were so some people were speaking like on behalf of 2 or 3 organizations. Some were speaking in their own right, like I think the lady who spoke for bipolar disorder. I think she was not supported by an organization. She spoke in her own right. And Ulrich,
Hallo
can you
Horst,
mute
ich
yourself?
kann gerade nicht telefonieren, weil ich bin in einem Webinar mit der EMA.
Close your meeting.
Okay, fine. And yeah, and then we also had a little bit of time left in the end where we could really also take a few other people from. Okay, Ulrich, can you hear me? Yeah. So I was just saying, so it was about 7, 8 women and victims, and 1 marketing authorization holder, about 6 healthcare professional organizations. Some of the patient groups were grouped because there were too many otherwise, and they formed coalitions, so to say. And we had also some time in the end for other people to take the microphone, so that was also great. And
yeah, my question is, it was public for the citizens in the European Union. Do you have a number how many people went to? I don't know whether you use Zoom or something in other tools.
Yeah, it was not Zoom. It was an in-person event, which was live broadcasted. So people from outside could not speak. So it was only who was in the room, and there were also observers. So we had about maybe another 60 people in the room who came as observers from academia, from other organizations, researchers, quite a variety of people who got additional access and were witnessing the event. We certainly would have statistics on how many people looked online, but I don't know the figures. But what I do know is, and that comes back to your question about how useful or important that change in the legislation in which you were obviously involved at the time was actually, and we have really, I mean, the survey was like people thought it was so important. They really wanted that public hearing. They were pleased they could come. They felt that they made a difference, and that was also true, and it was felt, and it was actually true. And also a lot of healthcare, patient representatives have told me that it's absolutely vital for a public body to have this option of engaging in completely transparent and open manner with the public. So I think this was one of the most important legislative changes we have done in 2012. And I think the challenge now will be, we had a second public hearing since then on fluoroquinolones, completely different in character. It was also at a different time point in the assessment process. It was more about gathering data for the assessment of the actual risk rather than about risk minimization measures, which was also included, but it was a different, very different kind of hearing. And I think
there is another one at the 11th of December about the corona vaccine.
That's it's called, I think, public workshop, if I remember well. It's not quite a public hearing because the public hearings in the legislation are linked to pharmacovigilance processes, but you're absolutely right. It's a public hearing-like event, also live broadcasted, so very similar in many aspects. And I think we will see more of that. If it will always be a fully fledged public hearing, or it's my very personal opinion, maybe we also need to find some mechanisms in between which are quicker and we can react quicker and engage quicker, because the public hearing needs quite some organization, and people can apply, and it needs to be reviewed, needs to be grouped. So I think we need probably different ways to engage in the public domain, different ways. But that's my personal opinion. But you can see with the COVID-19 vaccines, we have already taken action in organizing something rather quickly, and I think things are changing for sure, and it's getting more and more open, more and more public
and transparent. And transparent.
Transparent, correct? Yes, absolutely. Yeah.
And do you have some? Sure. So you have some information from colleagues from FDA about how they like or not the public hearings in FDA. So what are the information that we get from them?
Indeed, the FDA has a long-standing tradition of public hearings, and I was actually I spent a fellowship for a short while in 2012 at the FDA, and I could also witness one, which was very interesting. It's again for them it's really business as usual, and they have a lot of routine to people speak, and it's a different atmosphere maybe because it's more routine process. They also have advisory committees to which I believe stakeholder representatives are invited as well, if I have understood that well. So that's they have so much experience. I think I haven't seen, to be honest, I haven't seen a paper which really analyzed from the FDA itself, which analyzed how they evaluate their own experience. I might have missed that. I haven't seen that paper. It might be there or not. But I have read from an academic institution reflections or an analysis of a public hearing on a medicine, and it was very interesting because they raised questions which we also wonder ourselves. It's not unique to the FDA, but it's like, for example, who is the public, and how and also that in that specific instance it was also discussed that when you gather evidence, and you have your scientific standards of what you define as evidence, it's sometimes very difficult to involve patient experience, and if that is the experience with the medicine or the experience with the risk minimization measure, to actually classify that as evidence. And I have seen that myself when people talk about real world evidence. I always say for example, when you do studies on communication needs or information needs, that's also real world evidence. I mean, if you do a robust study and you solicit what do people need to know, what do they don't know, how they want to know, but there is still a reluctance. The real world evidence is very much what we find in big healthcare databases. It's a lot about a different, how should you say, data on finding relationships between use of medicines and certain health outcomes. And that other part, which also comes from the real world, is not yet considered so much evidence. So I think that's what we have to currently work on, and that's not unique to any jurisdiction. But so there are some learnings, and I think this is really what we need to think more in future. Yeah. Yeah.
Okay, do we have any? Thank you so much, Priya, and all of you for your comments and your questions. And do we have any more questions or comments? No. Okay. I would like just to have a few slides to show a few slides about our next event that you don't have to. You must not miss. First of all, we have the next meeting will be on the 9 and 16 December, and it's North America ISOP chapter organizing this annual meeting. And we are very glad that we have already started our collaboration with them. And together with Marco Tucori and the Italian chapter. So this meeting will be on the impact of COVID-19 pandemic on both the three topics: pharmacovigilance, drug development, and healthcare practices. So personally, in ISOP Israel, we have brought two of our experts from our advisory board. Peter Pitts, who was previous FDA Associate Commissioner, and Professor Gideon Cohen, who is a very renowned pediatrician and toxicologist and pharmacologist. So, as I told you, we have now many countries participating to our meetings, and I'm very glad of that. Next meeting is also in France, this time on 7 December, and it's for general public and healthcare professionals, because healthcare professionals are not all virologists or immunologists, and many of them don't understand what is mRNA vaccine. So the idea is to present facts and fight against the infodemic. The presentation is about the panorama of a scientific breakthroughs. Sorry for the mistake. And this is our great project to have a real conference showing all the aspects of the vaccination, open to general public and healthcare professional, and of course with highlight of vaccines, and in collaboration with many institutions and other chapters. And we believe on multidisciplinary integration, implementation, and so join us and be with us for our next meetings. You have everything recorded on our ISOP Israel website. And I will be glad to have all your questions and see you next time on our next events. So any question? So I thank you all of us for your participation. And I hope that you will come back at our next meetings. Bye, all of you, and I wish you good holidays. It will be holidays for everybody in Israel, and also for Christmas and New Year's. So thank you so much. Bye-bye.